Let us start with session 5 of evidence-based process. What we need to know is what is the effectiveness and the clinical relevance of whatever articles which we have searched and found out. And this effectiveness and clinical is the critical appraisal part. So you have to appraise to apply the findings and research to the patient under consideration, to understand the implication of research finding for individual patients. These are the two main parts which we need to do. Critical appraisal is the process of systematically examining research evidence to assess the validity, research and relevance. And critical appraisal to help to develop the necessary skills to make sense of evidence-based. This is in essence what is critical appraisal, because we want to apply whatever research is there to our individual patients, and that we should know first what is the effect on the population, and then on how it can be applied to your individual patient. That is in essence the fourth step of evidence-based system, and that is critical appraisal. So you find out the main thing you want to do is validity, reliability and reproducibility. There should be validity, means whatever research is there, it should be correct and valid. There has to be reliability, that we can rely on the results of that particular finding. So how do you start critically appraisal? Studies which don't report their methods fully overstate the benefits of treatment by around 25%. This has been the finding which has been there. And when funding is done by pharmaceutical, there is 4 times more likely that the results may be skewed towards the pharma. So you have to stop and think and find out what exactly is the research telling us. These things which are there about funding and all, their effect which is there has to be negated before you start thinking of utilizing the critical appraisal by critical appraisal. So how do I do the critical appraisal? First of all, use your common sense. That is the most important thing. You don't have to be a statistical expert. That is taken care of by calculators. Checklists help you focus on most important aspects. Every research method has got a checklist. So you use those checklists. So it will help you out. Different checklists are there for different type of research. So see that you are using the right one. And this will help to decide if the research is valid and relevant. The final aim is to find out validity and relevance. Now once you have conducted the literature search and obtained articles, you can begin the critical appraisal process. That is the first step. Consider the following questions to assess the quality of the study. So now let us go ahead and see what are the different questions which we need to ask if you want to find out the reliability, validity and repeatability of the whatever different things we have. So the questions which we have to ask is it of interest? Why was it done? How was it done? What has been found? What are the implications? What else is of interest? Now this is where the whole thing lies. Is it of interest? Means is it applicable to your patient? Why was it done? If you find out the reason why the researcher has done it, then whether it is applied to your patient or not, you will come to know. How was it done? That methodology will tell you whether you can apply it to your patient. What has been found? So you look at the results of that particular and find out what is the meaning of the statistics, and then their implication. That means how does it imply to the patient finding? That is what we have to find out. So it's not just a fault finding exercise. Don't think that evidence-based education system methodology is to find faults at different research. No, they are meant to appraise the research. Is it of interest? That is, look for the title and abstract. Why was it done? Look at introduction and should end with a clear statement of the purpose of the study. If that is there, then probably you will be able to make out that the first two questions which is there can easily be made out by going through the title, the abstract which is given, the introduction which tells you whether your thinking of for your patient and the researcher's thinking, do they match? Because unless they match, the results of that will not be valid. How was it done? So look for the methods, an important guide to the quality of the paper, because the methods will tell you how good that quality of the paper is there. Wrong methods which are utilized does not give you the right result. What was it found? So look for the result. The data should be there, not just statistics. Means how the patient data was taken and how it was done. All those parts should be part of the result. Just statistical mumbo jumbo will not help us, and that is why we need to see appraise it very properly. As far as that. Then what are the implications? Look for discussion. How far the results can be generalized to your patient? Is it relevant to any patients, or the population of the research and your population, is it same? What else is of interest? Look for the useful references. Find out more about the subject through the references. And some important novel ideas may be present which may not be utilized by the author in his work. That also if you start taking it, then that is what you are doing is critical thinking. So introduction tells you the earlier research findings, and should also include the literature review if it is separately given. Hypothesis often found in the last paragraph of the introduction. So what exactly is he implying to study, and it also could be in the aims and objectives also. And methods, who are the subjects of the research, what procedure and instruments were used in the article. These are the things which you need to find out from the article which you are trying to do the critical appraisal. The methods are the most important part, because how the subjects were utilized, what kind of randomization was there, whether blinding was there or not. All those things which are there will be given in the method. So the entire structure of your article need to be really understood before you can start thinking of applying to your patient, and that is in essence what is critical appraisal. Then comes results. What were the results? Were they statistically significant? That is what you need to find out. To what extent did the results confirm the author's hypothesis? Now, discussion, normally we do not advocate that it should be written because there is a lot of hypotheses there, pathophysiology or biochemistry has been put in to augment the result. Actually, what we have to find out is what the results are there. Discussion should not influence us wrongly, and that is why in critical appraisal, discussion should be at the last. Then you have to use simple checklists which enable you. So these checklists are available for each and every research type. We can have checklists. And they are very quick and easy way of learning the art of clinical, because they are given in point form. So you just keep on ticking mark and writing into the boxes which have been given, and then you will be able to really judge it better. You could have your own scoring system also for each and everything, so that your critical appraisal would depend on not only on what is written on the checklist, but your scoring of each of those points which are there. So we need to find out what is the basic question in the checklist, what are the basic questions, what are the essential questions which are related to the appraisal part, and what are the detailed questions which augment that particular appraisal. So this is what you have to look into the checklist. Just looking at the questions is not enough. What do the checklists ultimately mean is important. And if you see the consort guideline which is there, normally randomized control trials should be identified there. Now these are the guidelines the checklist itself is different, but the points, this is the explanation or the guidelines of how the points are to be utilized, which is there in the checklist. So title and abstract, what should be present? For introduction, what should be present? For results, what should be present? What is the baseline data? What are ancillary analysis which are there? Whether harms are taken into consideration or not. And diagnostic study, you have another ones. STARD also is another one which is there. Quadras is there, and you have the BMC's research methodology, which is basically QUADAS. So they also have that, and you have to give the scoring in that, and you will be able to do it properly. So after doing this, what is the next thing which you need to be doing? What goes ahead? Then comes your clinical judgment. What is your conclusion? What were the results telling you? What were the methods telling you? All these are the questions which you need to answer. So statistics and clinical importance generally is given by the p-value. So it is the significance of whatever research has been done. What is the significance of that you need to find out. Otherwise, if you don't understand that, then the appraisal will not be taking place. So you have to see to it that the standard of care which needs to be given to the patient is basically dependent on significant statistical analysis, and confidence interval has been taken or not, and the p-value is taken in the chi-square test or not. That you need to know. The clinical importance also should know, where the statistics not just for the sake of security. Then you should know for what is the level of evidence. The research methodology which has been utilized, is it a case report or is it a case control, whether it is cohort, randomized control trial, or is it secondary publication in terms of meta-analysis and systemic review. Systemic review and meta-analysis are good because it takes in consideration a lot of trials and combines them into one. Whereas randomized control trial will be only one. So cohort will be one, case control will be one. So these are in lower order depending on the research value and applicability to human clinical situation in the patient care. For example, in vitro may show very good results, but whether it can be applied in vivo to the patient or not, even animal studies can give you good results. But then animal research does not always translate into human being. So that differences which is there, we should come to know. Case reports and are there, basically should be utilize that to make a research project. Rather than using it for evidence, we should use it for creating a research project. Case control studies, because they have no controls, then it becomes difficult to, randomization is not there. So not all levels are equally useful for making patient care decisions. So you should know the greater the relevance of that topic, the lesser and the fewer are the available literature. So you are limiting yourself when you limit yourself to systemic reviews or randomized control trials. You are already trying to limit the number of articles because there are not that many. There are more case reports and things like that in literature than valid evidence-based research, which is what we are aiming at. We need to apply it to our patient. That is why. Now, two important concepts are there for this. A well-conducted meta-analysis or systemic provides stronger evidence than a single study. So always go for this, because more than one study is being coupled together, joined together. And it is only as good as the individual studies. That is also important. If the individual study itself is faulty, then your meta-analysis or systemic review are not going to act that well. So that has to be taken into consideration when you are trying to do that. Evidence has always contributed to clinical decision making. keeping current with the relevant research may be impossible, and that is why you need to search at the time of point of care rather than study it and try to remember and retrieve that. That is something which may not be possible for us at all. Knowing how to find the scientific evidence is something which you need to know. And knowing all these steps which is there is what is going to take you into the realms of critical appraisal. The PICO question is the starting point, then comes the search. Once it comes, then you come to the critical appraisal. For patient with dental deposit and periodontal disease, do oscillating Oral B as compared to sonic toothbrushes better reduce dental deposit. Now this is a question. If you go for the PICO, then powered toothbrushes, oscillating, sonic, dental deposits and periodontal. These are the keywords which comes out from that PICO which you have already done. And thus this, if you start putting up in PubMed, then you will start getting abstracts and articles depending on whether they are full articles or whether they are abstract. Full articles will also be available through PML. So that should be done. Now if for this particular PICO, if you have to go ahead and do it on PubMed and using these keywords, you will get many articles out there. Now, one of the studies for the articles which are there showed no benefits between sonic and toothbrush in reducing microbial count. Another study showed significant reduction in plaque and bleeding scores with large sonic toothbrushes. So here the outcomes were different. This is not the outcome that we are trying to find out. We are trying to find out outcomes is on the plaque and this thing. So then that is the problem. Another study had used rotary toothbrush, and there the plaque and gingivitis in adult periodontitis was studied and to be found to be effective. In other two studies, Oral B shown to be significantly more effective than sonic in reducing them. So when you go through all these studies, you come to know that yes, the rotary toothbrushes are effective and they are better than sonic toothbrushes. And the main thing is, what was the outcome? The gingivitis score and the periodontal health, those were the things, and that is what was evaluated. So evaluation has to be done with at 360 degrees. You have to see the results from all different angles, and if you do that, only then you will be able to make out. So let us see the different contexts and what are the different questions for that context. Could the selection be biased? So were consecutive or random samples there? So that is the indicating question. If the randomization is there, then bias is less. Second question is, was case control design avoided? Because case control randomization is not possible. So that is out of question. Did the study avoid inappropriate exclusion? So if many a time the specific exclusions are given, so and the results appear to be better. So enroll all patients randomized eligible for that with the suspect. The need to treat, that should be proper. Inappropriate exclusion should be not there. Difficult to, if the patient you feel is difficult to diagnose, if you avoid that, that is a problem. Studies should be enrolled with consecutive patients should be there, and with known disease and control group without the condition may exaggerate. So if you are enrolling those into the study group where you know the disease pattern, and in control group you are putting those patients where the control you do not have any idea of what is, then your results may appear to be better, and that will not be a true evaluation, because ultimately what you need to do is to get the best evidence, so that, and there should be absolutely no bias in that. Are the concerns that the included patient and the setting do not match the review question? So your review question which was there, the aims and objectives, that should be reflected properly into your results part. So patients included in the study should be in relation to the review question. Severity of the conditions, demographic studies should not be so widely that you get a heterogeneous group. So heterogeneity in the grouping should be avoided as far as possible. Large tumors are there in one group and the smaller other. Then the large tumors on the radiograph, and if you are going to use radiograph, then it is very easily caught. And so then your results will be different. So if you have large lesions and smaller lesions, then there should be equal number of large and smaller lesions in both the groups. Then only then you know that the results can be comparable. The results can be that proper randomization also has been used, and that results the comparison then when it comes out will be the true comparison. Then you have to take the index test, since it is a diagnostic procedure. Could the conduct of the interpretation of the index have introduced bias? Because the indicating question is, was the index result interpreted without the knowledge of the reference standard? So reference standard and this should be done separately, which is called as blinding. So blinding in introduction studies is most influential. And if you know if you have the knowledge of the reference standard, then it will influence your index study also. So bias will be introduced. The personal bias will come into picture of the person who's doing it. So indexing is always conducted and interpreted prior to reference standard, because reference standard is the basic standard which you have been utilizing throughout. The index test is something new which you are trying to try out. So first do that, and don't go to reference standard where you have the knowledge about it. If a threshold was used, was it pre-specified? So the threshold which is used should be optimum, both in terms of sensitivity and specificity, and this should be able to give you very good results. Independent sample opinion in whom the same threshold is used, it should be comparable to those patients also. So in all this, we have to see to it that the threshold is such that in both the groups you are doing it in a proper manner. Are the concerns that the index test and its conduct? So just as you did for the index test, the reference also review question also would be done. Variation in test technology, execution of interpretation may alter the diagnostic accuracy. So we have to see to it that the index test method vary from those specified in the review question. Then in that case, it is not important. For example, using a large transducer, maybe you use 13 megahertz, and in comparison time you are using 4 megahertz. Then in that case, the difference is bound to be there. Sensitivity and specificity of that test will be different. So you see the review question, the aims and objectives, and then you decide what the index test and the review test both should have the same type of machinery. The reference standard is also important. Could the reference standard, its conduct and its interpretation have introduced bias? And that is most important. Just as you did the index test, the reference test also should be done without the knowledge of what the index test results is there. The assumption is that the reference standard is always 100% sensitive, because that is the test which you are continuously using. So the knowledge of what the reference standard is giving should not be available when you are doing index tests. So specific disagreement between the reference standard and the index tests are then assumed to result of incorrect classification by the index. So index test is found to be poor if the reference standard results are known to us prior. So you will tend to do the classification wrongly for the index text. Your index text results should be totally unbiased, not known to anybody. Even the patient's name should not be there for confidentiality. So all those things should be taken into consideration. What is the another indicating question? Were the reference standard result interpreted without the knowledge? As I have already said, that also should be done in the same manner, that it should not be correlated with the index test. Index test should be done separately. The reference test should be done separately. Flow and timing. Could the patient flow have introduced bias? So indicating, was there any appropriate interval between the index? Because if you have taken the index text, the patient is already in that view about the index text. So when you conduct the reference immediately afterwards, then there will be discord and the result may not be proper. A delay is required, but the delay also should not be so much that patients start recovering in the intermediate time and or probably deteriorate also. So in that case, the second test will have different results. So when you want to comparison, both the conditions should be same. So timing should be proper. Were all the patients included in the LSA? And that is why dropouts make a big problem. The intention to treat, which is used by the 2x2 table, that is the way you have to go. So you have to see to it that all the patients are included, because otherwise it will create bias. If you allow the dropouts to be taken out of the equation, then the results may be wrong. Now let us see what do we look for. Let us see the agenda which is there for us. Can we trust the accuracy from the study? So you have to use what is called as Rambo. Rambo, the first three parts, RAMM, that is the recruitment, maintenance and measurements. The first three parts, RAM. Recruitment, was the appropriate spectrum of patient was used. Maintenance, all patients subject to the gold standard, means the method in which the test was done, was it same? And measurement, was there independent, blind or objective comparison with the gold standard? It should not be that the same person is keeping on doing both and then he gets biased. So it is always better to have a gold standard, and towards that checklist it should be there. The first thing part is the population part, which you see. Was the evaluation part. Now you have a heterogeneous population. Then what was the population in the index text and what was the population in the comparative test? So that is most important. Now as you can see, I have colored the people in different shape. So you come to know that they are not the same. The index test, there are two of one kind and one of the other kind. And in the contractor, first of all, there are 4 in place of 3. So this outcome measures from this can become different, because ultimately you are taking percentages. So if the total number of counts in each of the tests is different, will be different. And since we are taking a random sample, the population use, how the population is being used, that is important. For example, in the 2400 general election, when random sampling was done by each of these institutes, everybody had different results. And the final BJP tally was totally different. So that is the methodology. If you are going to use random sampling, that random sampling should be easily framed properly. For example, you have a target population. From that you take the sample frame. And then from that sample frame you choose the actual sample which is there. And then you have the complete data regarding that actual sample. Then in that case, that data which is there will represent the target population itself. And then what we have to know is what kind of standardization has been used. The measurement standard should be same for all. you can't use high threshold for one set of tests, and for the other set of tests use low threshold. Both the tests is going to give you different results. So high threshold and less threshold in any of the tests should be standardized. There cannot be differences in the methodology. So the measurement, blinding and objectivity, all these things are to be taken in consideration. That is the MBO part of your Rambo, and that is how Rambo helps you in finding out whether the conduction of the research is proper or not. So let us go for how to evaluate the students, the results of that research which is there, and that is one of the most important part of the evidence base. Are results due entirely to natural variation? 100 patients with acute ulcerative gingivitis were treated with metronidazole, 97 recovered. So is this recovery? This was a question which I had asked in the previous also. The recovery rate should be the same. Suppose that in a similar group, untreated patient, 10 recovered without having given metronidazole. In other words, extra 80 to 80% patients recovered from that particular point. This difference which is there, we can consider as metronidazole to be effective. But the same thing is with smoking and periodontitis. You should also know how many non-smokers also develop periodontitis. That will tell you the difference between one group and the other group. In one group, you have given the medicines or the treatment, and you have found out how many people are, the frequency you have found out, that how many people have recovered. On the other part, you have not given the treatment, but still you have found some amount of people recovered. It is that difference which is there, is the true difference between treated and non-treated patient. It cannot be just a minus thing, minusing one from the other. So misleading claims can come up because of that. The biased presentation in interpretation of data is the important, and that is for that methods and results section you should read, and discussion should be only if it is required. Abstract is required, should be evidence based in the secondary publication. Read the abstract properly. Faulty comparators should be avoided. Composite endpoint should be taken into consideration very carefully. And small treatment effect should not influence the major treatment for which you are trying to critically appraise that. And beware of subgroup analysis. You have to see what is in the main groups, not in the subgroup. Subgroup effects can unnecessarily influence or bias your opinion in the major part, and your main concern is the chief groups. What is the difference? Whether you can utilize it for your patient. Subgroup may be so many different kinds of subgroups may be there, and that may not be applicable to your patient. So read only the method and result and bypass the discussion. This is an example. Systemic examination of the relation between funding conclusion have found that the organization, when they do, it was 4 times more towards the product of that particular funding agency. So the thing was biased because of the funding group. The results were not entirely true because statistics which were used were modified in such a way that it appeared to be good. Should the comparator have been another active agent? So why many a times people use placebo. Now placebo, when you compare, always the result will become better. But if you are comparing it with another agent, then the placebo may not, and then the result difference may not be so great that you have to go for other formulation or dosage or administration regimen, because it could be more costlier doing it. If it is costlier, then it should have surrogate endpoints should not be utilized. True endpoints are those which have clear, direct and clinical relevance to the patient. The main true endpoints are pain, tooth loss, aesthetics, quality of life. All these are tangible. The patient can understand them. But the Carey ratios in the DMF index is therefore a true index, because it is a index which is there. It is measured and then presented to the patient. So patients are also able to understand that some amount of calculation has gone into it, and that's why this particular endpoint is good, valid, and can be utilized for our purpose of applying the result of the research into for the patient during decision making exercise, where patients as well as doctors and the administrators all sit together. Surrogate endpoints are measured that do not have an obvious impact on the patient. So they are not tangible but intangible. Periodontitis can be measured by the pocket depth or attachment level. Not always, and these are not really, patients are not able to understand that properly. What really matters to patient is whether the teeth are going to be lost or that pain is going to go away. A 2 mm loss of attachment or gaining of the attachment after the treatment does not really matter to the patient, because he does not see that. It is not tangible enough for him to understand and find out that yes, this is definitely a good treatment effect. The evidence of routine scaling and polishing is an example in dentistry. When a mixture of true and surrogate plaque, calculus, pocket depth, attachment change, bacteriology are all easily used as not as the main but as surrogate also. And this surrogate may appear to be better, and that is why the results are better. When you are applying to the patient, you need to have true, not surrogate endpoints. They should be clinically relevant. The outcome should be clinically relevant so that patient understand that. How much affect the routine scaling is generally very scanty in our literature. Most use surrogate outcome, and no conclusions are there. That's why surrogate are used because they provide objective information quickly. For the doctor, it is very good, because he can show the difference between them, but the patient does not understand. And evidence base is basically patient oriented, not doctor or student oriented. And that is why ultimately why the doctors, why the students are in the healthcare business, because for the patients only. So it is the patient's value which is there, and that's why today all our education is on patient centric and not student centric. So what is the clinical relevance? And that is what is the ultimate test for us. Your research evidence is there, you have taken the system, the specificity, sensitivity, likelihood ratio, ROC curves have been used. So now let us see the how it has been changed. The size of the effect of the treatment is called as the effect size. How large it is there or how small it is there. Are the observed results a real effect or they are likely to be a chance finding? So that is the part of bias. And research results should always be based on a sample of patients. So you should be able to repeat the same research project answer. Effect size, bias and repeatability are the hallmarks for finding out whether it is clinically relevant, that particular research is clinically relevant or not. And that is why you have to do all these measures before you can start applying. So the difference between statistical significance and clinical significance should be known to you very clearly. And statistics always dazzle. Now a comparison between Brennemark and IMZ over dentures was being utilized, and it was found that the bone loss which was there afterwards was 0.5 millimeter in Brennemark and 1 millimeter in IMZ. So statistically, when you did the p-value, 0.003 was there, so which was very highly significant. But is it 0.5 millimeter of any importance? Clinically, that 0.5 millimeter would not matter. Then why do we have to say that Brennemark is better than IMZ? So you have to do a 2 by 2 table here also, On one side is the size of the benefit, on the other side is whether the patient is able to understand the benefit. Tangible, intangible on one side, and size of the benefit, large or small, on the other side. That will give you the 4 levels: level 1, level 2, level 3, and level 4. And each level this has a different meaning and connotation as far as the patient is concerned. The patient will view this in different categories altogether. So even if your treatment is good, even then the patient should understand. Intangible benefits cannot be realized by the patient. Changes in probing line and all those things if you are using fluoride, the remineralization which takes place of the enamel, that they are not able to appreciate. The size of the radiolucency in the before and after you open the root canal, that also they probably might understand, but in most of the time they don't realize the importance. Tangible benefits should include improved oral health related, quality of life should be improved, and that the patient is able to understand. A decrease in self-reported symptoms. The symptoms should be utilized for your endpoints, and bleeding and brushing. So then patient understand that properly, not the signs. The prevention of tooth loss also is very important. Eliminating of the pain in the periodontal lapses, that is important. Patient understands very easily. They are tangible. The size of the treatment effect is also important. The implant support denture, again suddenly from edentulousness he gets teeth and he starts chewing. So that is the effect is great. Scaling improves on the bleeding. That also they are able to understand the effect, that they can see the effect. Bleeding has stopped. And in endodontic treatment, the pain also stops once. That is important. But chlorospheric mouthwash reducing streptococcus pneumoniae, that effect is very low, because the patients do not really understand that kind of effect which the result chlorhexidine gives. It is a very good drug, but unfortunately the results are not tangible as far as the patients are concerned, and that is why sometimes the size of the treatment effect does not percolate to the patient. So clinical significance was treatment of clinical significance are the magic bullets. There are the miracle cures which are there, where both the results are tangible, patients understand, and the size of the treatment effect is also very large. The use of vitamin C for scurvy, bone marrow for leukemia, the use of implant supported dentures to treat edentulism. These are the kind of magic bullets. Immediately on the day which these things are started, within a short period of time, the patient sees the dramatic change in the disease level as far as he is concerned, or the functional level as far as he is concerned. So in all these matters, the results can be easily perceived by the patient, and he can understand and the effect also is very large. From out of nothing, when there was so much of bleeding, vitamin C suddenly stops everything. Tangible level 2 has a tangible benefit, but the treatment result is very small. So in these conditions, you need to use randomized control trial to really find some effect. So using of penciclovir in treatment of herpetic lesion, the effect may not be so dramatic, but the patient can see that the ulcers have gone, but the pain may not go down as quickly as is required. So that is the most important finding, that this is level 2, where the tangible benefits are there, but the treatment effect is smaller than in the first. In clinical significance 3, they are intangible treatment, and the results, but the result size is large. So opening of the root canal and immediately pain relief is there, but that doesn't mean the patient can understand that. He just understands the pain. He doesn't value the biomechanical preparation and things like that. In clinical significance 4, you have the tangibility also, intangible it is, and its treatment also is very low. For example, you have the lipid levels, or drop in blood pressure, decrease in pocket depth. These are the things where patients do not understand. It's only when the report comes they will be able to. Physically they do not understand that. And at the same time, the effect is very low. Many of the, even if the blood pressure has dropped, they may not realize it. Lipid level has dropped, they may not realize. Only when the second test is done, then only they'll come to know that yes, their lipid level has gone down. And that is why such treatments are leveled at level 4, where it is intangible and the effect size also is very low. So journal clubs should be utilized, and statistics should be done on your own. Free calculators are available, so don't get afraid of statistics and all those figures and formulas which were there. They can easily be done. Research design you should understand, and be skeptical of tests. They just give you probability. They don't tell you whether the patient has the disease or not the disease. And learn about therapy, causality, prognosis and harm, and evaluate all the results in 360 degrees. See to it that you see everything from different angles, so that you are able to grasp the essence of what the statistics and what the result of that research is telling you, because you want to apply that to your patient, and that is why it is important. So remember one thing: every step which you take for signs and symptoms evaluation, each of them has got its own sensitivity and specificity. The likelihood ratio, positive as well as negative. So take everything with proper care. When you are doing all this in a thorough manner, then you are probably able to reach your diagnosis much better when you utilize all these parameters. So see to it that you do it everything properly. Same as with TM joint, whether it is disc displacement using MRI, or you are doing a palpation, you are trying to find out digital degenerative changes. What is the main problem towards using of education system? When you ask people, they say, should I be using it? Must I? My boss is not interested. Why should I be interested? I am shielded by my boss. Even if I don't know evidence base, it does not matter. And I am in my comfort zone. So I need not go ahead and do the evidence. Evidence base is something which you need to work on. The new skills have to be developed on. And that takes you away from your comfort zone. If you are not able to do that, then you will be in the same rut all over again. And what has been done years back will continue to that. So the next part of our